Welcome, everybody. My name is Karen Dietrich, and I am the Director of Advanced Care Planning Canada at the Canadian Hospice Palliative Care Association. It is my pleasure to welcome you to Breaking Barriers, Building Palliative Care Everywhere. I'm joining you today from the unceded territory of the Algonquin Anishinaabe people. It's my pleasure to be here today, and I want to thank you all for making the time to join us during Hospice Palliative Care Week. I'd also like to thank and acknowledge our sponsors who have made our campaign this year, Palliative Care Everywhere, possible. So thank you to the St. Elizabeth Foundation, GSK, Innovative Medicines Canada, and Purdue. A lot of our activities would not be possible without their support, as well as everyone for taking the time to join us here today and learn more about some great initiatives that are breaking barriers to ensure that everybody has access to palliative care wherever they might be. For those of you who might not be as familiar with the Canadian Hospice Palliative Care Association, we are the national voice for hospice palliative care in Canada. And as that national voice, we work with provincial hospice and palliative care associations across the country, national and international leaders, as well as champions and a range of professionals from different sectors and practices. We do our work through public policy, education, awareness, and knowledge mobilization. We believe that everyone in Canada deserves a holistic, compassionate, and person-centered care when they are faced with their own or a loved one's life-limiting illness. Unfortunately, this is not our current reality. And so I would like to invite you to join us, to join CHPCA in demanding for better access to palliative care by visiting chpca.ca/advocate to learn more about how you can get involved. I am very excited to be hearing from our three speakers today. And so you'll hear a little bit from all of them, and then we will have a panel discussion, and then you'll have an opportunity to ask some questions. Hannah Irving is the Director of Philanthropic Programs for the St. Elizabeth Foundation, a national registered charity working to strengthen community healthcare through innovative models, partnerships, and leading practices. Hannah's going to talk to us about Reflection Room and Journey Home Hospice projects. After Hannah, we will hear from Gloria. Gloria Pervine is the project manager and knowledge translation lead for the Nav-CARE project, a volunteer program that aims to alleviate social isolation and provide service and community navigation. And following Gloria, we will hear from Sharon Kasalainen. Sharon is an associate professor in the School of Nursing and an associate member of the Department of Family Medicine at McMaster University. And she is one of the national research leads for strengthening a palliative approach in long-term care, often referred to as SPA-LTC, a program that ensures people with life-limiting illness have more opportunities to experience a high quality of life while living in long-term care residences. And so with that, I'll also invite actually members who are joining us here today. If you can put your questions in the Q&A area, that will help us to monitor and make sure that we're addressing as many questions as possible. You can put your questions in there at any time during this session, but we will be bringing them forward later in the webinar. For the chat, if you're having any technical issues or have different comments you want to make, feel free to put it in the chat, but the formal Q&A portion will be in the Q&A section. And so with that, I will turn it over to Hannah. I'll just stop sharing so you can jump in there.
Thank you so much, Karen, and thank you to CHPCA and everyone here today for the opportunity to share two innovative programs we're really proud of at St. Elizabeth Foundation. Journey Home Hospice is a hospice specifically serving people experiencing homelessness and vulnerable housing. We were founded in 2018, and the hospice is operated by the St. Elizabeth Foundation. Our pilot site was in downtown Toronto, Ontario, and we've now expanded with our first satellite location in Windsor, Ontario in 2022. Journey Home Hospice is unique because it's specifically serving a very vulnerable and different type of patient. So the patients who come to Journey Home Hospice typically also come with mental health issues, a history of substance use, and often very traumatic histories, whether that's personal interactions with the healthcare system, and really kind of an experience of being overlooked, marginalized, perhaps not having their voices heard well. So in order to provide specialized care, we have 24/7 beds and a wonderful interdisciplinary team that operates on a holistic model of care, acknowledging pain and symptom management, psychosocial needs, and spiritual care. And part of what we've done at Journey Home Hospice to really meet the needs of our patients is to also develop managed alcohol, opioid, and cannabis programs where our patients are still able to use the substances they wish in a safe, prescribed, and monitored way so that we can minimize interactions with medications while still meeting their needs, helping them feel at home. And, you know, nobody wants to meet end of life and have a whole list of rules and regulations they have to follow. We really want the space to feel like home, to, you know, be welcoming, and for our patients to be able to form trusting relationships, not only with our clinical team, but also with our volunteers and complementary therapists. So one of the things we're doing through Journey Home Hospice as well is serving as a teaching and learning facility. So both for healthcare workers, for organizations, and we've brought in people from actually across the world who want to learn about the specialized model of care we have and how they might bring it to their own organizations and communities. At St. Elizabeth Foundation, we're very much committed to sharing information, to enabling others, and we're always looking for partners who may want to work with us or may want to invite us into their own communities. So there's been some great development in the 5 years we've been operating Journey Home Hospice. As I mentioned, we were founded in 2018. In 2020, in the height of COVID, we still managed to get community support from, you know, both individuals in the area and wonderful donors to expand to 10 beds. We did a subsequent expansion in 2021, opening 3 chronic hospice beds that are currently unfunded. And they are a more flexible model of care for patients with a prognosis of 6 to 12 months. We like to say we don't want to throw anybody out for failing to die. In a traditional hospice, most of us in this work know that a typical prognosis is up to about 3 months. But our patient needs can be unique, and sometimes with good hospice care and a safe environment, they can do a little bit better. So we have this new flexible model of care, which offers them the perfect hybrid between housing and healthcare with a little more independence, while at the same time still maintaining that access to clinical services, meals, and a safe place to sleep. And also, as I mentioned, in 2022, we were invited by the City of Windsor to open our first satellite location, responding to the needs of the community, where homelessness had doubled, you know, in less than a year, very rapid and expanded need. So we have 3 beds in that area. We've been very lucky in all of our developments to partner with social housing, with Homes for Society in Toronto and Assisted Living Southwestern Ontario and Windsor, to build a more sustainable model of care right in the communities where our patients live. So, you know, that's part of what we want to share and what we want to develop for other organizations and communities so that you too can bring this care in a sustainable and, you know, responsive way. I do find the best way we have to highlight the care that's offered is to hear it directly from our patients. So I'm happy to share Nicole's story with you now.
You could be a soccer mom driving your SUV, and next thing you know, you're an addict on the street. I got married, had a great job. My husband at the time was very abusive, and he ended up hitting me in the back with a hammer. So I got prescribed Oxy 80. The addiction escalated. I lost the place, and I lost my job. Never imagined they'd take my kids away. And for me now to have cancer, I don't want to die an addict without my children and without having some kind of quality of life, because otherwise I would die on the street. And no one would know that I'm just a normal person that had a hard time, right?
Nicole's story is so powerful, I think, because it really showcases the needs of our patients, some of the unique stories they come to us with. and the need to create care that responds to individuals. Part of breaking barriers to palliative care and bringing it everywhere is responding to the needs of all people in the community. And for, most Canadian cities and, places across the country, homelessness is a problem we're all working together to address. Another project I'd like to touch on briefly is the Reflection Room. So the Reflection Room is a participatory art installation, which was created by the SC Research Center in cooperation with other institutions as part of SC Health's greater commitment to social enterprise and action-oriented research. So reflection rooms basically create a quiet, meditative space. There's a few elements we add to help create that sense of peace and calm. And the idea behind them is to ask Canadians to engage in conversations about dying and death, about grief and loss, and to create a safe space where they can share stories and read the stories of others. So the Reflection Room has been offered since 2016 in installations across Canada, and really has focused on that storytelling piece as a connecting factor between people. One of the interesting things we did during the pandemic was adapt the Reflection Room for installation in long-term care homes in Ontario and beyond. So the Reflection Room was unique because it can be used by yourself. Social distancing practices are not a problem, but people still participate in it as a sense of community. So what our research is starting to tell us from the long-term care project is that although users typically engage with the space individually, whether they're staff, volunteers, residents, family members, that the Reflection Room not only helps them to work through grief, which may be related to death, or during the pandemic, for a lot of people, it was related to other factors, loss of the ability to gather, loss of a job, loss of income, loss of stability, and helps people to tell those stories and at the same time read the stories of others so that they can feel less isolated and alone. There's a sense of community and connection that comes through the storytelling process. So as part of National Hospice Palliative Care Week and our commitment to bringing options for palliative care everywhere, St. Elizabeth Foundation has gifted a Reflection Room kit to over 200 hospices across Canada. Our hope is that they'll be used to help start conversations and support grief and bereavement journeys across Canada. So if you'd like to bring a Reflection Room to your organization, please reach out to us or visit us online, where we also have about 1,500 reflections stored if you'd like to read them. And again, I have a short video to show you what a Reflection Room is actually like.
All the deaths were terrible experiences, but all of them also taught me things which I am more than grateful to have learned. Patience, forgiveness, compassion. That first lonely summer following my husband's death, when it felt like I was also grieving the loss of myself, that the happy woman I always was had somehow died too, I would come to know a joy deeper and richer than I ever knew before.
Grief is a universal human experience, whether caused by dying and death or indeed through other forms of loss. But we usually don't think about grief, and we don't talk about it much in our society. The Reflection Room offers the opportunity for storytelling to help people think about experiences surrounding grief and loss. You can come to a Reflection Room and read other people's stories. You can reflect on your own experiences with grief, and, if you wish, write your own story and add it to the reflection wall. By sharing stories, people will become more comfortable with expressing grief and loss. The Reflection Room has traveled extensively to public and community spaces all across Canada, and you can also read and share stories online.
Thank you again for the opportunity to be here today and to share our programs, Journey Home Hospice and the Reflection Room. My contacts are here. I'd invite you to reach out if we can help to support you with any of these programs in your home communities, or if you have questions about other work we're doing. Thank you again.
Wonderful. Thank you so much, Hannah. And we will get a chance to hear from Hannah again later this hour, but now I'll turn it over to Gloria.
we go. Thank you so much for the invitation to join you this morning. For me, I'm here in Vancouver, and thank you to CHPCA for hosting this session. It's a real delight to be here. And I'm going to be talking about the Nav-CARE program and the role of volunteers in building palliative care capacity. So Nav-CARE, which stands for Navigation, Connecting, Advocating, and Resourcing, is a social innovation in which experienced, trained, and mentored volunteers provide quality of life navigation in the home or community for individuals and families experiencing declining health. Volunteers are trained to identify the day-to-day challenges persons are experiencing as a result of declining health and to assist them with connecting to persons and community-based resources that can help. Volunteers develop long-term relationships with clients by visiting them regularly to facilitate connection and support. And clients who seek Nav-CARE services are often those who are at risk for social isolation or have limited capacity to solve their day-to-day challenges. Nav-CARE was designed to occupy that sort of in-between space between professional care and care by family and friends, both relationally and functionally. Healthcare can't do everything that is required for an upstream palliative care, a palliative approach to care, and family and friends often don't have the time or their own resources to provide that wraparound care either. And so Nav-CARE can really help fill that gap. And to date, Nav-CARE has been implemented primarily through community-based hospice palliative care societies, though we are expanding beyond this. So the goals of Nav-CARE are really centered around the notion of quality of life navigation. And this is not healthcare navigation. And I understand that these are not easily discrete concepts and that healthcare is an essential part of quality of life. But there's so much more that goes into quality of life that is not within the purview of health and social care that can make a radical difference. So the first goal of Nav-CARE is to facilitate a palliative approach to care in which persons are identified early on in the illness trajectory so that proactive support can be provided. The second goal is to really develop that volunteer capacity. Volunteers have a real role in palliative care, and often their contributions are not maximized and their skill set often not leveraged. Third, it seeks to optimize the services and resources that are available to clients in the community. Our research in palliative care in the rural areas really have revealed how difficult it can be for persons living with palliative needs to identify and access these resources, or they don't have the time or energy to access these resources. And our research has also showed how many communities have organic resources that almost no one knows about. And so pooling those ideas together and then connecting clients to these resources is a very important part of the Nav-CARE program. And finally, the Nav-CARE program seeks to provide a practical program to support a public health compassionate community approach to care, an approach in which persons are supported in the social aspects of care within their community. So what do Nav-CARE volunteers do? As mentioned earlier, they have the time to build long-term relationships, which allows time for them to listen deeply and be responsive to the evolving needs of clients and their families. And which is really important to really getting a tapping into then the resources that are within the community. So they can help assist with tasks that persons with declining health might find challenging. They can connect them to the supports and resources that are in the communities to meet those daily needs. And importantly, they can provide a safety net for those living at home alone or without family nearby. So I wanted to emphasize that helping with daily needs. As you can see from this list, this is where that in-between land of health and social care just do not support. And all of these are really concerns that are directly impacting the person's health, but don't fall within that purview of health and social care. So this is just not friendly visiting or overcoming social isolation. And so, for example, someone with cancer can find that their treatments can be very costly, and they don't know that there might be a little bit of financial relief for them. And so a volunteer can really help navigate to that, help them fill in the forms and submit an application for that financial relief. Or another example, maybe around maintaining friendships and relationships. Someone with declining health can feel that their friendships wane because of treatment time commitments, or that people are uncomfortable around them now because of illness. And so they can help reconnect clients to these relationships that are meaningful to them. So Nav-CARE, the evidence base for Nav-CARE was developed over a decade of research, which began with ethnographic work in rural palliative care under the direction of Dr. Barb Passett at the University of British Columbia in Okanagan and Wendy Duggleby at the University of Alberta. I'm not going to go into this, and I encourage you to check out our website if you're feeling so inclined to read about the research. But I just wanted to identify where we're at right now, and we're in the scale up and sustain aspects of this project. And with a contribution from Health Canada, we're now implementing in over 45 organizations across Canada. And this is a list of where we are. And not all of them are receiving support from Health Canada, but others have just implemented on their own, and have implemented or just starting to implement. So it's very exciting to see this grow across the country, and across, actually, we're implementing in Europe and have implemented in New Zealand as well. So it's very exciting to see this grow. But I wanted to just talk about a few of the innovations that are happening in these sites. As you can well imagine, it's very different across this country. And, you know, as a program, we have this vision of what this innovation can look like. So what is actually happening on the ground? So I kind of to talk about breaking barriers to increase access, I pulled out maybe four innovations that have been happening. And the first one, the barrier, is that lack of community awareness of hospice organizations, regardless of what program they have to offer. Some sites have said, you know, we're in the same building as other health service providers, and they still don't know about us. So they have been putting a lot of effort in raising awareness about their hospice organization. For those organizations that have been funded by Health Canada, we've asked them to commit to presenting to 5 different organizations, and across the country over this past 2 years, more than 300 presentations have been made to just build this awareness. And what's been really beautiful about all that kind of work that they've been doing is that it's really yielding some collaborative working relationships with other community stakeholders. So for example, with paramedics or first responders, seniors support services, and so on. And it's really, these collaborations have been to optimize each other's reach within the community and identifying all those different clients that might be needing support from different types of organizations. So the second barrier to access relates to communities that have limited to non-existent access to healthcare services. Many of our Nav-CARE sites support communities in remote areas where there are little to no service. And to help identify client need, these sites have been developing something that they're calling community ambassadors. People who are from the community, they're well known in the community, and have time to liaise with the hospice organization that's outside of this community to mobilize resources and advocate for additional resources. This is a very new development in some of our hospice organizations, so I'm really excited to see how this is going to progress over the next couple of years. The third barrier is this inconsistent access to volunteers. And one of the things that I'm really noticing across sites is this idea of creation of a volunteer pod. And so you can well imagine that volunteers are asked to do a lot, especially when clients have high needs. This can lead to burnout and volunteers leaving the program. So in addition to offering ongoing volunteer mentorship and support, sites are creating these volunteer pods. So rather than having a 1-to-1 volunteer ratio, it's a 2 or even 3-to-1 ratio depending on the client need. And the advantage of this is that it can minimize the burnout and then minimizing the exit of volunteers from the program, but also promoting consistency in care. So the client has a cadre of volunteers, so to speak, that can support them. Then the final innovation rests on supporting the continuing education needs of volunteers. As you can imagine, that there is just this very wide variety and diverse client base that volunteers work with. And so depending on the kinds of needs clients have, sites offer tailor-based, practice-based education to volunteers to ensure that they have the knowledge and skills necessary to support those needs. And a really interesting and innovative example of this is one of the hospice organizations in Alberta is developing a really comprehensive education package for volunteers to support people living with dementia and their care partners, whether that's in home or in long-term care, long-term care homes. And this, I think, is really building the confidence for volunteers to be able to work with that population, and giving families and individuals living with dementia another touch point to help them along that journey. So those are just a few of the barriers and how these sites have increased access in their areas. And that's not all of them, but that's just a little snapshot of what they do. So if you'd like to hear more, please do contact us, either through our website or to email us directly at the UBC address there. And thank you so much for your attention and for listening.
Thank you so much, Gloria. It's always really interesting to see all the different ways that people are tackling them, and how much we can relate when we hear it and go, oh yeah, I can see how that could help, or I've run into that before. So wonderful. Thank you. Now we'll turn it over to Sharon. Wonderful. Thanks, Sharon.
Great. Well, first off, really want to thank CHPCA for organizing this great event. Am I off mute? It's telling me I need to unmute myself. Okay, good.
You're good.
Cool. Yeah, so I want to thank CHPCA, Karen in particular, and Nick, who's the background fellow, who's making this all happen. It's great to have this leadership across the country, and I think the work that's happening at CHPCA is really raising the profile of advanced care planning and palliative care. So thank you so much for that. And thank you for allowing me to co-present with my other co-presenters. And really, I have to say, really excited to hear about the excellent work happening across the country. So fantastic. I think we're leaders in the world, and really, excited to hear more about all of the things that are happening. So I'm going to switch gears a little bit and specifically focus on the work that I do and my team around strengthening a palliative approach in long-term care. So my team and I, we've been at this for a while. We've had a number of studies, and over the course of 25 plus years, we've really seen the population in long-term care change. So we started off, seeing the need to implement a palliative approach, and now we're seeing, shorter lengths of stay for residents. They're coming in, on average about 18 months is how long they live in long-term care before they pass away. But that trajectory is getting even shorter. And we're also seeing a population that's very frail. They don't just have one chronic condition, they often have, 2 or 3. it makes it very challenging to provide adequate care and quality of life. So lots and lots of challenges in long-term care to implement a palliative approach. The other piece to all of this, throwing into the mix the high prevalence of cognitive impairment dementia that we're seeing in this population. So upwards to about 75% of the residents in long-term care have dementia. It's usually what brings them to long-term care. But with that, you can imagine the challenges with having conversations about values, preferences for care, and what's important to them at end of life. So often we don't have that opportunity by the time they come to long-term care, and we rely on family members to have to make those important decisions. And often, they're having to make them in what we call crisis mode, with very little preparation, very little time to think through some of these things in order to make a decision. And we're seeing, that falling into grief and bereavement. So families are having issues with their grief and bereavement, feeling guilt, feeling burden. And I think there's so much we can do to minimize that. So the other piece really is around the staff in long-term care. I would say I teach in the nursing program, and we don't have a lot of content around supporting and caring for people who are dying. And I think given, the types of staffing we see in long-term care, which is 80% unregulated healthcare providers, PSWs, healthcare aides, they have even less education and training. So here we have a very challenging population, and not that well-equipped healthcare provider, human resource capacity to support them. So you'd think with all of these challenges, our team would have walked away and tried something a little simpler, but we've stuck with this area of research and very committed to it now. So all of our research is informed by participatory action research. So this is a type of research I like. It keeps me close to data, close to residents and families and clinicians, and we learn from them about gaps and what their needs are, and that helps inform our strategy, what tools we need to develop, our implementation strategies for these tools. And really, it's intended to create sustainable change in our system. This is really just a kind of a summary of some of the tools we've developed over the years. You can see we have 4 pillars that really ground our program. So preparing for future changes. So preparing residents, families, and staff around what people can expect within a particular condition as the condition worsens and declines. And the goal really is to help prepare families for end of life so they're well informed to make those critical decisions. Improving quality of life and comfort. So here, we have pain management which is always on the top of everyone's list to help promote a peaceful death. Strengthening relationships. This has become even more important. How do we help build relationships within residents, within families and staff, and among the hierarchical staffing levels we have as well. It's hard to do good work when we don't have positive relationships. So a lot of our tools are focused on that. And then, of course, building organizational capacity within the long-term care sector. As we know, they're very under-resourced. And what can we do, given the resources we have, to help build capacity? So one of the things we quickly realized, and really wasn't a surprise to us, we need education and training for all staff. So for the most part, I would say nurses, physicians are given the opportunity to attend different education around palliative care. We have LEAP long-term care. We have the PACE program for PSWs that CHPCA offers. but often we don't have education for dietary, recreational staff, all of those other people that have an intimate role with families and residents. So we did just a 2-hour communication workshop. And what I want to show in this slide is, the personal support workers or care aides and the support staff had the lowest levels of comfort with communicating with families, providing palliative care. But after attending just the 2-hour training session, their comfort increased the most. So that told us, we really need to support that sector. And so we went on to develop quick e-learning modules. There's 8 of them. And really, we tried to make them as short as we could. So people, they don't have a lot of time in their day, between 8 to 12 minutes each module. And what are the nuggets we feel are important for all long-term care staff to know? Another strategy I've learned from my palliative consultant colleagues here in Ontario is around comfort care rounds. We've done some work on that early on with Mary Lou Kelly with some of our earlier studies. But essentially, it's a way to bring staff together and support them with someone like an expert in palliative care, if we can say that, whether it's someone from outside the home, within the home, to provide mentorship and space for staff to debrief about previous deaths. If there's, often there's some lingering issues that they're struggling with, a death that maybe didn't go as well. And then while they're reflecting, there's opportunities for learning and education. So having a palliative consultant there can help provide that in the moment education that can be quite beneficial. So this is work that we moved on with CHPCA. Thank you, Karen. And we realized not all homes had access to external palliative consultants. So, and we're starting to see, more capacity building within the homes. So these are different scenarios, common scenarios that we've seen over the years. And it provides really kind of a framework for internal facilitators within the home to be able to lead their own comfort care rounds. We have a number of podcasts, really kind of cool podcasts. We try to get diverse perspectives. We have a death doula. We just did a podcast with my old childhood friend who's a funeral director, because we're realizing, they really have expertise around grief and bereavement. So what can we share from their expertise that may help others working in long-term care? We have different professionals, different type of healthcare providers, really kind of cool things when if you're in, bumper to bumper traffic, nothing else to do, you can always tune into a podcast. The other resources, this is probably one of our most popular resources, and they're even being used outside of long-term care. We've developed some informational pamphlets. So based on, the 5 common conditions that we see in long-term care: dementia, heart failure, lung diseases, kidney disease, and then, frailty, which is kind of a catch-all for all these diseases, to give families and residents and staff some information about a particular condition, some of the signs and symptoms that may start to emerge as a condition progresses, and some common questions that they may want to ask their healthcare provider. So this is just a 3-page kind of pamphlet we fold, and we just put them up in the homes for people to access when they feel they'd like to read more about it. During COVID, we worked with CHPCA to develop virtual resources. So this is the same information on our pamphlets that can be downloaded in a digital version. Some work originally, Tamara Sussman, who many of you may know, she's a social worker at McGill. She led the pamphlets and the 2 studies here that I'm reporting on. But essentially what we heard from residents and families, the pamphlets helped encourage reflection, help them to clarify what questions they want to ask. Sometimes they didn't know what it was they actually wanted to ask until they saw the question, and gave them a little bit more, comfort about talking about some of these issues. So that was a good thing. The other piece that we noticed when we developed these pamphlets is we were helping to prepare families and residents and giving them questions to ask, but the staff weren't always comfortable with answering these questions. So we thought, well, we better do something for staff, while we needed to. So we again worked with CHPCA, and these are all on the CHPCA website. Some conversation guides for staff on how to respond to questions that may emerge from residents and families about these particular topics. As residents approach end of life, there's different conversations that need to happen. In our work, we recommend a palliative care conference, which is a little different and often relates more to developing some goals of care or treatment decisions. This, to be honest, I think is our golden nugget in our program. We've seen, great success with reduced hospital use at end of life. Families feeling so much better after attending a palliative care conference, saying, this is great. I feel like we're all on the same page now. So it's really important. I don't know why we don't do it more in long-term care and why it has to be such a big deal. It just makes perfect sense that we engage families to have, the kind of conversations they need to have with physicians and nurses and get their questions answered. Another tool here, I'm sure I'm going over my time. This is a booklet, fantastic booklet, highly recommend. It's in, I don't know, and gets to the nitty-gritties of information that we hear from families that's important. And finally, wanted to talk a bit about some of the work we do for staff around reflective debriefing. We have a short video here we developed with some colleagues in the EU. 10 to 12 minutes, that seems to be the magical time to make these learning resources. And then we have like a handout to go with it to help staff walk through some of their own grief and bereavement together. Another booklet, one of my favorites, Paulette Hunter and some of her colleagues in Saskatchewan developed. It talks about different rituals around bereavement care, and she had an artist draw the pictures, so it makes it even nicer. And finally, we have a community of practice. Karen is my co-chair. I don't think we're ever going to be able to stop being co-chairs, Karen. We have this kind of worked out. We've been at it for a couple years now, I think. It's been a while. We just had a session today and it was fantastic. So it's trying to bring people together primarily in the long-term care world, where we can network, learn from one another, share resources. There's so much siloing going on across the country. We really want to use this community of practice to bring us all together. So I welcome you to join. You can see there the link for the sign up through advanced care planning. And that's it for me. How far am I over? Oh, not too bad. Not too bad.
Thank you so much, Sharon. That was wonderful. I always tell people there's so much happening at SPA-LTC, and see what I mean? There's a lot of tools and resources. So thank you so much. Before I jump into my panel questions, I noticed that a few of our panelists have been answering questions in the Q&A, so that's wonderful. It helps to kind of keep it moving. Maybe just really quickly for you, Sharon, do you happen to know, oh wait, maybe it got answered already. Actually, the question was to Nick, but I'm not sure that Nick knows. Is there a cost to the courses you were talking? I think those are the modules. I think maybe that was the question.
Yeah. I'll put the links in as we talk, but they're all free. Yeah, it's all open access and free. So yeah, I'll add the links now.
Okay, perfect. So just as you get a chance to peruse that, I'll just start with some question. Maybe Hannah will start with you. I'll pose this question to everybody, but I'll ask Hannah to kick us off. So we've heard about, everyone has shared successful tools or projects or approaches that leveraged existing resources, maybe in new ways, to increase access to palliative care. So thinking of your examples, how did you identify existing resources that could be leveraged to address gaps in services?
Yeah, thanks, Karen. That's a great question. I'll answer it with respect to Journey Home Hospice specifically, because that's where we've really found that utilizing community resources has been the key to our success and sustainability as a program. So when we originally piloted Journey Home Hospice in 2018 with 4 beds, we worked with Homes First Society, which is a social housing building, which graciously gave us the space to start our pilot. And like many hospices, we thought we'll do an independent build, we'll, custom create something. And, we ran into 2 challenges. One, it's downtown Toronto and real estate is unspeakably expensive. And 2, when we were speaking with and surveying our patients, we got to know them. Although the neighborhood we're in is interesting. It is the neighborhood that our patients have lived in. We're right across from the Salvation Army shelter. We're really embedded in the community where our patients live and have street families and connections. So by building a new hospice, Shangri-La somewhere, we'd be removing them from their communities. We'd also be creating barriers for their friends, for their street family to visit because of income challenges. And quite honestly, they were happy where they were. We said, what would you want in a new renovated hospice? This, but more. So that's what we did. We built more beds. We now have 2 floors within Homes First. And we took that same approach when we opened our Windsor satellite last year in November, finding a partner in the social housing space who would be able to offer us space. And that way we can also leverage the resources we both excel at. We have partners who know how to handle building maintenance, and we're really good at clinical care. So by coming together, by creating a rent situation, a collaboration, we're able to leverage our own strengths and talents and create a more sustainable model of care, because you take out a lot of the upfront capital expense of purchasing and creating a new hospice space when one can be repurposed.
Makes sense. Wonderful. Thank you. I see Sharon, I think, is answering questions or reading. I think that's what's going on. So Sharon, you keep answering, you keep pondering. I'll turn over to Gloria. So Gloria, how did Nav-CARE identify kind of those existing resources that could be leveraged to address the gaps that you guys had identified within the community, that kind of what you call the middle space?
Yes, it's a really great question. And I think there's 2 parts to that for us. And in the early development of Nav-CARE, to really inform the research, really inform the curriculum development, the researchers really met with community advisory groups. So they did preliminary interviews with community stakeholders and others to identify the barriers and resources for implementation. But then on the other side, what we're asking hospice organizations to do is really leveraging their existing relationships with other stakeholders within the communities, and then pooling their ideas together to see how they can best support all the different needs that are arising in the communities. And then the volunteers themselves, we ask them, we teach them to do what we call a windshield survey. So that's looking at what are the resources in their communities, and they know so much about their communities, and it's one of the motivating factors for them to volunteer with hospice organizations, is they know how to connect people to these different very organic kind of resources. So that's the kinds of things that we do for leveraging these existing resources, is really pulling on people's ideas and knowledge of those.
Wonderful. Thank you. I'm hearing definitely a theme of collaboration, definitely a theme of engaging with a lot of people and engaging early. So thank you for that. Sharon, I don't know if there was anything that you wanted to add to that question around identifying those existing resources that could be leveraged to address the gaps in services and the available tools. I know you guys developed a lot of tools, but kind of anything around that.
Yeah, I think it's, it's similar to what the other the other two were saying, we did do, a couple scoping reviews. We're academics. That's what we do. So, did a couple scoping reviews to see what's out there in other countries as well. So use that. And all of our work is really co-designing with people who are using the tools. So to make sure that, they were actually going to be meaningful to them and not what we thought would be meaningful. So I think that helps, it helps kind of meet their needs and helps with getting them the uptake of people using them.
Absolutely. Thank you. I'll just turn to the Q&A. So Aisha, hi Aisha. So she's a patient advocate and she's asking about, could the speakers kindly comment if there are opportunities for volunteers or community workers, caregivers to receive education on competencies for dealing with these vital measures of palliative care? So I'll start by just saying one thing that I learned actually this morning with Sharon is that Compassion Alberta has recently launched an online education. I'm not sure I wouldn't say it's a course, but it's specifically designed for the public. So maybe not exactly what you're looking for, Aisha, but they released it, I think, 2 days ago. So if you go to Compassion Alberta or Compassion Alberta, I'll find the link and make sure I have the right one. That's one new resource that I recently learned about, but I'll let the panelists answer about anything in terms of learning opportunities for volunteers or community worker caregivers.
I'd be happy to jump in here, Karen. So several years ago through our research center, we helped to develop a course. It was aimed more specifically at non-clinical workers in the space, so shelter workers, social workers, that kind of thing, to have conversations with especially people experiencing homelessness, but it can really be applied to any person about palliative care, end of life care, that sort of thing. All the resources are available at no cost online, and I will include the link as well if anyone wants to check those out and make them available. Also, we have a wonderful resource called Care Channel we developed that has videos in 6 different languages that is designed specifically for family caregivers and volunteers to show them how to safely care for a loved one at home, basic skills on how to transfer somebody from a bed to a wheelchair, help somebody with dressing, all those sorts of things, and lots of written resources as well. So I'll link that one out in the chat as well for you.
Awesome, thank you. So we do have a few minutes left. Was there anything else that anyone wanted to add before I move forward? I think we have an active Q&A going on. That's okay. There's engagement virtually in lots of different formats. That's completely great.
There's a question, Karen, from Maxine around the PPS. I can't read the whole question. I think it's around using the palliative performance scale.
Yeah, I think the question just ends there, to use this method for a family.
Oh, okay, right. Yeah, so it's a great tool, and it's a tool that we definitely use in our work. It's not a perfect tool, and I'm just wondering why maybe the family refused, or if it was the home that refused to use it. I know there are some people that think it's maybe not the best tool for long-term care. It was developed for the community, for a cancer population. But we don't have many other good options. And we have found it work for a few reasons. We find PSWs, healthcare aides, are able to do it themselves. And by using it, it's a way they can communicate to RNs about resident decline. So it's a nice kind of team-based tool that way. It's very simple. And based on our work, it actually does predict, people who are dying soon. So I wouldn't dismiss it. The only, I think, I don't know if there's another piece to that, maybe that, once you start focusing on palliative care, it means you actually need to do something. And maybe homes don't feel, ready, to kind of address that. But it's a great tool, and yeah, we generally find good feedback from homes about using it.
Yeah, so Maxine, I think or the anonymous question, there seem to be a couple there. I think reach out to the SPA-LTC network. They absolutely can maybe provide some information, knowledge, tools, and resources that you could bring forward or direct the home to learn more. That would be one.
We actually have a little e-learning module on how to use it. That might help.
Yeah. Sorry, Isha, let me go back to your question without sharing the top portion. So just to provide some context to that original question. So as a patient advocate, Aisha finds all the initiatives focused on are impressive aspects of efficiency at the individual level, yet all individuals, including the seriously ill, are social beings whose contexts of care are critically impacted by many upstream factors, not only social, but also ethical and regulatory issues. Thank you. Sorry, in the essence of time, I was trying to get to the question part, but I understand the importance of the context there. I'm reading the whole thing all at once. Yeah, and I think and it's hard sometimes with the chat. I know that because we have such a large attendance, we can't kind of open the phone line, so to speak, right now. But I think absolutely it's that whole person. It's those gray areas that get missed. It's the understanding where people are. It's a lot of, I think, what we've heard before of, not before, but in the answer to that first question. It's big, right? It's big. People are human, we're complex, we have a lot of relationships, and we're all very diverse. And so I know we have 3 minutes left. And so with that, I'm actually very quickly asked the panelists, if you had a piece of advice for others in palliative care who are seeking innovative approaches to increase access to palliative care in their communities, what would that piece of advice be?
I can jump in.
Sure.
I think really involving the community, community organizations right from the get-go, right? The beginning, from the very beginning, involving them in adapting innovation in the community. So it's in the community, by the community, and for the community. And I think that's a really something that we learned.
Wonderful. Anything to add, Hannah or Sharon?
I think I would add that you cannot underestimate the value and impact of volunteers. They're incredible resources. Some of them are so connected, and they very much are the heartbeat of the community. They understand the needs, they understand the people to talk to, and they can be incredible resources in creating collaborations, in forming partnerships, and in informing the work as well. So we really are grateful to all of the volunteers who support our programs, and they've helped us to learn and grow as we seek to bring palliative care to all Canadians.
Wonderful. Thank you, Hannah. Sharon, any final thoughts on advice for folks that are looking to innovate and think differently about bringing palliative care in their communities?
I would say it's a team approach. Find some like-minded, enthusiastic people with a passion, and work together. Use the community, use, others that are around you. And it's can be very organic, I think. So yeah, don't try from the top down. That doesn't work.
Wonderful. Well, a big thank you to all of you. Thank you so much for taking the time today to share information about your programs, the work that you're doing, your learnings, your observations. I think one of the learnings I think I've had in terms of any type of innovation or trying to create something new is don't, and I'm gonna mess up the saying, and there's probably someone who said it, but don't let perfect be the enemy of the good, right? So get started and learn and understand you're going to make mistakes along the way, and learn from those mistakes and keep pushing forward. And you'll learn more quickly if you're engaging with people in the process. So I think that would be something that I've seen is we all want to get it all right. And I'm a planner. I want it all laid out in front of me. And that's not really how life works. So again, a very, very big thank you to all of you who made the time to join us here today. The recording will be shared with you. And I hope you enjoy the rest of National Hospice Palliative Care Week.